Hello, good evening, and welcome to all on the Zoom platform for MahaIP. MahaIP President Dr. Gangolia sir is there. Today's speakers Dr. L.S. Deshmukh sir from Aurangabad, Dr. Amit Dad from Nagpur, Amit Tagare from Sangli, and Dr. Sandeep Kadam from Pune. All our speakers are there. This activity is brainchild of Dr. Mahesh Mohite, who is our academic guru in Panvel. So he is also there since the beginning. And today's moderation of the session will be done by Dr. Renu Boralkar. So she is also there. I welcome you all and all the audience members who have joined from Maharashtra, all over Maharashtra. So we'll start with the activity right now. First, I'll ask Dr. Gangolia sir to address the meeting and then we'll start the proceedings. Dr. Renu will handle the further proceedings.
Thank you, Dr. Nilima. Good evening and namaste to the respected faculty, dignitaries, guests of honor, moderators, office bearers of MahaIP, and all the attendees present on this Zoom dais and MahaIP YouTube channel. This is the second episode of scheduled 9 episodes of Maha Mentor Mentees. We are very fortunate to have the excellent mentor with its excellent mentees to discuss yellow eyes and skin of the neonate, which we see in our day-to-day practice, many times a dilemma of going about it. Hope so this session will resolve and relearn our thought process of dealing with these yellow neonates. A humble request to everybody, subscribe our MahaIP YouTube channel for the upcoming scientific sessions. Thanking in anticipations and wishing each one happy learning. Thank you very much.
Thank you so much, Gangolia sir, for your kind words. I am Dr. Renu Boralkar, your today's coordinator for this program, moderator. I now request Dr. Mahesh Mohite sir to have a few words with our August gathering. Sir, please unmute yourself.
Thank you very much, Dr. Renu Boralkar, and thank you very much, Yaman Gangolia and all the dignitaries on the dais. As you all know, the concept of this is basically take a clinically important focus topic and try to give subtopics of that from 2 or 3 faculty, which are, I will call them mentee. They are not actually students. They are themselves established consultants, and there is a super consultant. And today we have a super consultant, Dr. L.S. Deshmukh sir. Actually, he's teacher of many. He's teacher in neonatology of many. And to my knowledge, I suppose he was the first DM neonatology of the state. Am I right, sir? Dr. Deshmukh sir? I think he was the first that I know of, and he's teacher of many because I have seen his kind of a stature in the neonatal groups. So we have the best person today to moderate this. And I'm sure we have got many such sessions which will keep you attracted. With that brief introduction, hand it over to Dr. Boralkar. Thank you very much.
Thank you, sir. Thank you so much. We have our guest of honor today, Dr. Vinay Joshi, who is EB MahaIP from Mumbai. Is he available, ma'am?
He said he'll join in 2 minutes. He just
okay. We will take it later.
Yeah.
So now we will go towards the main program. Today, the topic for our program is neonatal jaundice. Our mentor for today is Dr. L.S. Deshmukh sir, who requires now no introduction, but still for the formality, I would like to introduce him. Sir Deshmukh sir is professor and head Department of Neonatology, GMC Aurangabad. He is past president MS NNF. He is a fellow of Commonwealth RCPCH London, fellow of International Society for Quality in Healthcare. He is also a member of editorial board, educational board of Journal of Maternal Fetal Neonatal Journal. He's a reviewer of BMI, also Quality Journal, Journal of Neonatology, Indian Journal of Child Health, Indian Journal of Case Reports. He is a member board of studies of MUHS Nashik, and he has many publications, national, international, to his own credits, and having many orations, awards, as well as he has a special interest in quality improvement, neonatal infections, and neonatal hyperbilirubinemia. So he is a Mahaguru That is what is for all of us. I would like to also introduce our next three speakers who are there as a mentees. Actually, as Dr. Mohite sir said, they are experts in their own field and not the student. But still, as we know, we have a mentees term, so I have told like that. So Dr. Sandeep Kadam sir, he is MD DM neonatology. He's a neonatologist, KM Hospital, Pune. He is a teacher for DNB neonatology. He has many publications in his name. Along with that, he has presented at many conferences, national, international, regional level. The next one is Dr. Uh, Amit Tagare. He is also a DNB neonatology. He is director and in charge neonatologist, Aditya Rainbow Super Speciality Children Hospital, Sangli, Maharashtra. He has more than 15 publications in journal, co-author of Neonatal Parental Nutrition Guideline 2010, faculty in national and international conferences, research interest in neonatal nutrition, non-invasive ventilation, and neonatal sepsis. The third speaker is Dr. Amit Dhananjay Dahad. He is MD Pediatrics with fellowship in neonatal medicine from Singapore, fellowship in echocardiography, MBA in healthcare management, and PGP in USA. He is currently director and head of Mother and Child Unit at Vidarbha Institute of Medical Sciences Hospital Private Limited, Nagpur, and director Geeta Medisquare Private Limited. He is affiliated to many national things like NNF India, NRP trainer, NNF faculty, breastfeeding task force, NEST trainer, and many more. And presently, he is the executive board member of AOP Nagpur. So today I have the privilege to hand over the mic to my own guru, my own teacher, and I bow before him, Dr. L.S. Deshmukh sir. Over to you for your few comments, sir, and then we will start the program.
Yeah. First of all, thank you, Maharashtra IAP and office bearers and Dr. Mohite for giving me this opportunity to mentor this session. And this type of format has been tried by some other state IAP branches, as Mohite sir must be knowing. And how it works and how it evolves, it may be a Maharashtra model tomorrow. I'm very sure with an active Maharashtra IAP is going to be that. And they have taken up this neonatal jaundice, which is very common and a common topic. And for this mentor-mentee, the selection of the mentees, I must mention, all three of them, they are experts in themselves, and they need no introduction. They will be presenting their cases, and simultaneously they will be taking you through various aspects of neonatal jaundice. So most of the aspects will be covered, I guess, in the three case scenarios which we are going to discuss. But however, we know in pediatric practice or neonatal practice, neonatal jaundice is the most common condition we come across. Almost 60% of the full-term babies and 80% of the preterm babies will have this jaundice. And many of those babies will develop clinically significant jaundice. To the tune of 10% of those babies will need some form of evaluation, some form of phototherapy or treatment. Of course, it is decided by the bilirubin level, but the bilirubin threshold which is used is very variable. In particularly in late preterm and term infants, they have to be classified based on these TSB levels. And then you need to be very careful while evaluating these babies. Secondly, there are two types of jaundice we come across in practice. One is an unconjugated, which is very common. But here I must mention we should not be overlooking the conjugated jaundice, which is very often neglected, and these babies usually will present after second week or third week, and they can have grave disorders, grave prognosis, and they need early intervention and evaluation. So with these few words, And one more important thing I must mention, there is a category of babies which I always mention. Babies which are discharged early. Within 24 hours, like in our hospital, babies are discharged next day. Those babies are not followed up for jaundice. We do not know what is happening to them, and they come back with severe jaundice. That category of babies, they are term healthy babies, but we need to look at the risk factors and ensure that we need a follow-up. Of course, universal screening has been recommended in some of the European and US countries, they do that. But in our country, I guess it will not be possible for screening all the babies. But in private practice or in outpatient practice, what I would recommend is pediatricians should have a TCB at least, transcutaneous bilirubinometry for screening. And based on that, plus the risk factors. And the biggest of risk factors which I always found is a primary mother, baby which is little late or early term, baby having feeding difficulty, mothers with cesarean section, and babies who are not followed up very closely. These are the babies who are likely to land up with severe hyperbilirubinemia and the problems. Another group of babies which we are not knowing or maybe we are not neglecting or evaluating is G6PD. We do not know what is the incidence of G6PD. It is variable. Of course, there is a meta-analysis which says that it may be 8 to 10% in India. But we are not evaluating babies for G6PD deficiency. That has to be kept in mind. And blood group incompatibilities, particularly babies with OA or OB setup, they need to be followed up very closely. Even if initially there is no jaundice, subsequently they can land up with the problems. So with these three case scenarios, the prolonged jaundice, the neonatal cholestasis or thyroid jaundice, the preterm jaundice and the term jaundice and the hemolytic jaundice is totally different category altogether. We are very conscious of it. We are very active in managing and treating. Unfortunately, some of the babies come late and these babies land up with the problems related to the bilirubin encephalopathy. So I guess these three speakers or three mentees will guide you through all the aspects of neonatal jaundice. Thank you once again, Maharashtra IAP, for giving me this opportunity.
Thank you so much, sir, for your kind words. Our guest of honor, Dr. Vinay Joshi, sir, has joined. He is EB Maha IAP from Mumbai. Sir, I request you to unmute yourself and please convey your greetings to this audience.
Good evening. Good evening, everyone. And nice to listen to Dr. L.S. Deshmukh, sir, after a long time. But I think it is a wonderful program, as I can see that, and definitely the speakers, all of them are experts in their own way. And definitely this mentor and mentee program, I think we are doing this similar kind of program in the pediatric intensive care group. And it has been a very, successful and liked by one and all. So I think this is going to happen same here, I am sure. And all the audience, will definitely benefit. So I thank the organizers for inviting me. Sorry, I got late because of I came home a little bit late after the evening OPD. So I congratulate the organizers and welcome the speakers, and they can start the program. Thank you.
Yeah, thank you, Dr. Joshi, sir. And now over to the speakers. They can start their sharing of the PPT.
Can I start?
Yeah, sir.
Namaskar, everyone. I thank Maharashtra State IIP and Mohite sir and L.S. Deshmukh sir for such a wonderful program. And today we will be talking about neonatal jaundice, and I will be talking about old problem. And with the current scenario, international scenario of Russia and Ukraine, we now know that the old problems are still the stronger problems. So I'll be talking about one of such problems in neonatal jaundice. This one was a 1-day-old baby who was referred. I got the call in the evening, and by the time the baby reached, it was almost 10 p.m. Birth weight was 2.8 kg. It was a full term, delivered at a PHC. And they had noted that the baby is yellow. So he was sent to a pediatrician and was investigated on the same day. And in the late afternoon, the bilirubin came back. It was 12. So he called, and then the patient was referred. So on admission, the baby had almost just crossed 24 hours. Was stable hemodynamics. Baby was looking deeply ectric. Now we should all understand the lights that we use nowadays. These are bit fluorescent lights, so all the colors, yellow, blue, all those appear bit stronger. So the ideal assessment of jaundice should be done in a broad daylight, but because this patient came late, on those lights it was appearing deeply ectric, but the baby was active. This was the third baby. Mother was negative, and the weight on admission was 2.6. So if we assume that the birth weight of 2.8 is right, so the baby had 7% weight loss in matter of a day. And this being March, it's already becoming very hot in our region. So what are the points to consider? The age was around 24 hours. Now, this is very important. When we talk about jaundice, we always talk about age in hours. We will never talk about day, because this patient who was just crossing 24 hours is still 2 days, and a baby who is around 47 hours will be 2 days. So when we talk about jaundice, we always talk about hours of life. Then mother is A negative and she is third gravida. So maybe immune hemolysis. We don't have any history. Baby was neurological normal. So these are three important issues. In a setup of immune hemolysis, a 24 hours old baby with a normal neurology. So what is alloimmune hemolytic disease? Now, this is one of the oldest problems that the neonatal world knows. And this has been a difficult thing in old days, which fortunately in last 2-3 decades in developed world, it's almost undercover, but still in developing world, it is a problem. So it is the most common hemolytic disease in neonatal period. Now it is alloimmune, so it is immune. So there are antibodies. There are non-immune, like as Deshmukh sir mentioned, something like G6PD, PKD. These are all non-immune, but this is alloimmune. So hemolysis of neonatal red blood cells by maternally derived IgG antibodies happens. Now this process may start as early as 20 weeks in utero, depending on the maternal exposure. Now, antibodies are produced when the incompatible fetal antigen enters the maternal circulation during pregnancy or shortly after it. So, as this tells, this initiation or sensitization causes the maternal immune response, and with repeat exposure, there will be a stronger response. What are the causes of alloimmune hemolytic disease? RhD incompatibility is still a big burden in countries with with a high neonatal mortality rate like India. It is a big problem in the countries with NMR more than 15, but even in the countries with NMR more than 5, it is important. ABO incompatibility. The O group mothers are a bit different than A or B mothers because they have IgG antibodies against the which are the anti-A and anti-B antibodies. In A and B mothers, these antibodies are IgM. So these IgMs won't cross the placenta, but this IgG will cross. With effective anti-D prophylaxis in the Western world and most of many places in India also, it is becoming a common problem is the ABO incompatibility. It can affect the first pregnancy because these are inherently IgG antibodies. In case of RH incompatibility, the first pregnancy is usually secure because it is the time when the exposure happens. But if we don't have a previous transfusion history or abortion history, this can happen in RH setup even in first pregnancy if we have missed that history and that exposure is not taken care of. Minor blood group incompatibilities or non-RH, non-DRH incompatibility like RHC, capital C, small c, can cause the immune hemolysis, but this forms a small group. But I had seen a patient which I'd actually discussed with Deshmukh sir when we had discussion. It was a partial D. So this mother, when we are checking her blood group, used to be RH positive, but when she behaved like a RH negative, and that's why we were getting consecutively 2 or 3 babies which had a very severe jaundice. Now we feel nowadays that RH is going, but the outcome of RH incompatibility in underdeveloped world is still very difficult. Now 50% of the patients have no chronic stress or don't need any exchange transfusion. But this was the paper which includes lots of countries, even India is part of this. And this was done over 2010 when published in Pediatric Section 2013. So if we see the neonatal deaths and chronic stress in 24% of the patients, 13% patients had impaired neurological outcome risk at 13% at 2 years, and stillbirths in 11%. So it is still a significant burden. Now we come back to our case. So what happened? Now what we ideally do is like once this such a patient comes, the first and foremost thing is we put him under intensive phototherapy. So intensive phototherapy was initiated. Now how do we define intensive phototherapy? Whenever our exposure is more than 30, we call it intensive phototherapy. So it is not on the number of lights, number of surfaces, nothing. It is the intensity of the phototherapy. So conventional phototherapy is 10 and intensive phototherapy is more than 30. IV fluids and tube feeds started because we did not want the baby to come out of the lights even for a short time for feeding. Relatives were counseled about a plan for IVIG, assuming that this is immune hemolysis. And we asked them to get the maternal blood because the mother was around 120 kilometers away. And if we need an exchange transfusion overnight, then it would have been a problem. And we have to have a blood which is cross-matched with both mother and baby. So the investigations came back. Hemoglobin was 14.4. Which is a bit lower. We usually expect it somewhere around 16 to 18. So probably hemolysis is already set in. The blood group, baby's blood group is AB positive. This DCT was grade 4 positive. The grade 4 DCT means the moment you mix the bloods, there is clubbing and then the clumps, and then the clumps disappear because there is a very high load of antibodies. So many times if it is seen a bit late, it may be reported as negative. It is that strong. Retic count was 21%. Bilirubin was 15.1 milligram per deciliter, total bilirubin. Serum albumin was 3.5 gram. Serum electrolytes we did because baby had lost 7% weight. So it was 146 of sodium, 5.1 of potassium, 4.1 of potassium and 5.1 of calcium. Blood sugar was 68. So what are the impressions from the investigations? So this is a RH setup with immune hemolysis, positive DCT and high rating and low hemoglobin. So these all indicate immune hemolysis is already set in, and this was an RH setup. And this patient definitely has a pathological hyperbilirubinemia. Now what should we do? The first thing when it comes to RH or immune hemolysis that rings in our ears is the exchange transfusion. Now it has to be definitely considered. Now this is the Bhutani charts. How do we read? It is very important to understand how do we read it. As in the first thing I told, the age in hours is very important. That is on the x-axis. Y-axis is the total serum bilirubin level. And then these lines. There are 3 lines as we can see. Now the uppermost line is the full term baby. Now we can read what is that. So it is infant at lower risk, that is more than 38 weeks, that is full term. Now we should understand one thing, when we talk about hyperbilirubinemia, a full term means more than 38 weeks. Not as conventionally we call 37 weeks. So more than 38 weeks and a baby without any risk factors is considered the uppermost or the minimal risk thing. So this is the line that we read for them. Now, if we see all these three lines on the first 24 hours are broken because we don't have enough evidence and we really don't know. So that is gray zone. The second line is the infant with medium risk. Now, more than 38 weeks or equal to 38 weeks with risk factors. Now, which are the risk factors? It is written here. Isoimmune hemolytic disease, G6PD, asphyxia, lethargy, temperature instability, sepsis, acidosis. So, anybody who has a risk of hemolysis or sick patient becomes a risk. Now, our patient at this moment consideration falls in this zone. He is a full term, more than 38 weeks, but he has risk factors. Now, at 24 hours, what is the level? So, this is 15, this is 16, this is 16 and a half, 17. So, somewhere 17 is the time of exchange. Now, what is conventionally done whenever a patient comes, if he doesn't have any neurological symptoms, then this patient is a fair patient to give a trial of intensive phototherapy. So that is what we did. We put this patient on intensive phototherapy, which was already there. We continued it. And then we discussed with the relatives and we administered IVIG, the dose of 2 grams per kilo. The serum bilirubin was checked after 2 hours of admission. So from 15.1, it came down to 12.4. Sorry, this is 26 hours. Then after 6 hours, 11.5. And after 12 hours of admission, it became 10.2. So it is falling. Now, role of IVIG. Now, IVIG has become famous in neonatology because of COVID. With MISN, we all are well versed with IVIG. Initially, it was used for sepsis prevention and then it went in disfavor. So in last decade, we are not using it for sepsis, but now it has come back with MISN, and it had a role in AIHD throughout these last 3 decades. So it is reported for more than 3 decades. I think the first report came somewhere in 1987. It reduces the need for exchange transfusion. Exchange transfusion is something that was a very common thing. Even in my residency, I had done so many exchanges. I still remember when I was in Australia, I was the only one who knew how to do exchange transfusion. So one patient who needed exchange transfusion, they had waited for me. So it has become slowly a very uncommon thing. And the very reason is it is a very life-threatening situation, doing an exchange transfusion. So the primary goal is avoiding neurological damage, and the secondary goal is always avoiding exchange transfusion. So IVIG administration is easier and safer than exchange transfusion, and it can be done in any unit, even a level 1 unit, where you can't do an exchange transfusion. So how does it work? It reduces the rate of hemolysis by non-specific blockage of Fc receptors on the macrophages. Now we should understand how the hemolysis occurs. The macrophages is the phagocytic system, and what it does, whenever it gets an indicated cell, it will go there and kill it. So that is what it does against its own RBCs, because it is now indicated by the maternal antibodies. Now what this IVIG will do, it will block those Fc receptors on the macrophages, so there will be reduced hemolysis. There is significant, and how do we know that this is actually happening? And this the carboxyhemoglobin levels are the sensitive indicator of hemolysis, and there is significant reduction in the carboxyhemoglobin levels in infants with positive direct Coombs test and who were treated with IVIG. So it reduces the hemolysis. That is the way IVIG works. And how do we take care of this jaundice? Is we have beautiful phototherapies nowadays. Very strong lights, LED lights, non-heating, effective lights, which reduce the bilirubin very rapidly. Now, whenever we think of anything, we always think about Cochrane. because it is the systematic reviews which gives the level 1 evidence. And Cochrane has a 2018 meta-analysis where 9 studies of 658 participants were analyzed, and they showed that the IVIG reduced the need for exchange transfusion. So it is almost 65% reduction. So if we see the relative risk is 0.35, so 65% reduction, and it is very significant. If we see the confidence interval, it is 0.25 to 0.49. So how much? If we treat 5 babies with IVIG, we can prevent 1 exchange transfusion, which is a good enough thing, considering the risk of exchange transfusion. So now if you read this meta-analysis deeply, then there will be subgroup analysis, and then there are trials, good quality trials with blinding, and then the significance comes down. But the bottom line is it works. Now, as in India, now initially when it came in picture, it was IVIG should be administered in less than 12 hours in at-risk patients. At-risk patient is a patient who has a positive Coombs test. So the patient has the evidence of hemolysis in a setup like a ABO or RH, where bilirubin is rising. Within 12 hours, you should give IVIG. Now, this showed that there is significant reduction. So there was the relative risk was 0.41 with significant confidence. The number needed to treat was 6. Now it is India. So in India, nothing comes on time. So jaundice will also not come in time. There are so many issues. Like many times we don't believe our labs. So people keep on repeating the samples and waste golden time. So most of the times what we get is the babies who are older. So they can be older. Older means I have a baby who came, I think, on 3rd day, 3 days. So he was 75 hours and bilirubin was 31. So that old they can be when they reach us. So more than 12 hours. So what happens with more than 12 hours? Still it works. The relative risk is 0.31 and number needed to treat is 4. So it definitely works. Now in our case, what happened? After 12 hours of admission, 1 phototherapy continued. So I had put him on 2 lights, and then I stopped 1 light because the bilirubin was falling. But it continued on intensive mode. Oral feeding under lights was initiated. Initially, I was tube feeding because I did not want to take any risk. Now, baby had normal neurology throughout, and hemoglobin at 12 hours was 12.2. So from 14 point something, it came down to 12.2. In 12 hours, it has dropped almost by 2 grams. Serial investigation showed falling bilirubin and hemoglobin, both. Now, this is very important. When we have a patient of immune hemolysis, it is not just jaundice, it is the anemia. And this anemia is one thing that can kill your patient. And unfortunately, since quite a few patients who died of shock and anemia because they were referred, by the time they were referred, their hemoglobin was 1 or 2 and they were already gasping. So what happens in jaundice? We are used to following bilirubins and people keep on following bilirubins and forget about this anemia component. So hemoglobin and bilirubin go hand in hand. So we have to follow them. So as the bilirubin rises, the hemoglobin drops. So on day 4, the bilirubin was 10.4, which was reasonably fine, but the hemoglobin was 9.8. So it had come down. It has, the hemolysis has slowed down, but it was definitely active. Now we should understand one thing, that in this AIHT, this hemolysis, these antibodies will remain. The half-life is almost 6 weeks. So these will remain active for almost 3 months. So we have to monitor these patients for almost 3 months for anemia. We are not worried about jaundice beyond 2 weeks of life, but this anemia component will remain, and this risk we have to follow. So baby was feeding orally. We had planned to stop phototherapy and check the rebound bilirubin, because this can happen with this, especially with IVIG. There was a bit concern about the rebound jaundice, but that is not that significant. But still, in such a patient, we have to check a rebound when we stop phototherapy and wait for some time. Mother was still admitted for some medical issue. Now relatives were feeling that the baby is anyways fine. You are stopping phototherapy, baby is feeding well. No IV fluids, no antibiotics, nothing is going on. So they demanded discharge. So this patient was discharged AMA. So we explained them the risk that this hemoglobin is going to fall. This may land up in shock, and this patient's jaundice can increase. The danger signs were explained. The referring pediatrician was called, and this patient was sent. Now they did not come for almost a week. Then somewhere on day 9, day 10, they called the referring pediatrician who was close by and told them that there was some issue. So he told, okay, you directly go back and check it. So they brought the baby on day 11. This baby was feeding well, was active, baby had gained weight, but baby was pale and no clinical jaundice per se. Now it becomes very difficult to assess jaundice in a pale baby. So in a pale baby, your patient jaundice, the bilirubin may be high, but the clinical assessment goes wrong. Exactly reverse in a plethoric baby, we always see all colors are strong. The blue is strong, the yellow is strong, the red is strong. So baby was investigated. Hemoglobin was 6.2. Retic was 12. It had fallen down from 21, but it was still high. And bilirubin is 11. Now what does it tell? This retic of 12 and hemoglobin is 6.2 tells us that it is a hemolytic jaundice, because these patients beyond second week of life, or sometimes end of second week, are at a risk of hyporegenerative anemia. Now this can happen in RH patient because the bone marrow is suppressed. Now there are multiple theories about it, but in this patient it is hemolytic jaundice, because hemolytic anemia, because the hemoglobin has fallen but retic count is high. So the current issue is ongoing hemolysis. Hyperbilirubinemia is not significant for age. 11 is not very bad for 11 days old, and the patient has anemia. Now, has IVIG treatment anything to do with the transfusions? The early IVIG, that is less than 12 hours, in first 12 hours of life, when we administer IVIG, there is no increase in top of transfusion during first week of life, during second week of, beyond the first week of life. But in late IVIG, the need for transfusion after first week of life is slightly increased. So this is important. So we have to understand that this can happen, and these patients are at risk of anemia and need transfusion. So this baby received packed cell transfusion matched with both mother and baby. Now this is once again important, though it is not exchange transfusion. Whenever we are transfusing any patient in first 3 months of life, the blood should be cross-matched with both mother and baby, because we still have the maternal antibody load in the baby's body. Folic acid supplementation was initiated because we have already transfused. This patient is already hemolyzing, so he is already iron overloaded. So we don't need an iron. So just to induce his the hematopoiesis, we need a stimulus, that is a folic acid, because these patients will consume a lot of folic acid and become folic acid deficient. Now, as a routine, OA was done like all babies, and it was passed in both years. Now the discharge plan. So this time this patient was reasonable. They realized that there is something wrong, and this is a serious disease. So we explained them the plan for hemoglobin monitoring. The post-transfusion hemoglobin was 12.4. So we explained that you follow after 1 week, and we will once again check his hemoglobin, and we will need to check it for intermittently till we are absolutely sure that this is not falling, and this may take up to 3 months. Now, OA pass doesn't mean this patient is audiologically safe. We have to have a BERA at 3 to 6 months to confirm that his the hearing is absolutely normal. Regular OT visits for tone assessment and early intervention, which is usually we start at 3 months and we continue every 3 months, at least up to 1 year, ideally up to 2 years. So this discharge plan was explained to this baby. Now, can we eliminate kernicterus? See, some things look very difficult, but incredible things can be done simply if we are committed to making them happen. It has been achieved, almost achieved in Western world, developed world. So why we can't do it? And as Deshmukh sir has mentioned, we have to have a plan when we discharge a patient. Now, where patients are discharged early, like 24 hours or 36 hours, then we should know how do we decide that which patient has to be followed. So this is how the risk zoning is done. Now, this bilirubin level can be checked by transcutaneous bilirubinometer, which is a very costly apparatus to have. It costs somewhere 2 to 4 lakhs. But if you have it, it is good. So it can become a screening thing. And if the levels are high, then you can consider checking the blood levels. Or you can do a total serum bilirubin level. So this is how the zoning is done. So this is the low risk, low intermediate, high intermediate, and high risk. Now this depends on age in hours and bilirubin level. Assume I am discharging a patient at 24 hours and his bilirubin is 3. So it's a low risk zone. Now at 48 hours, I have discharged and my patient's bilirubin is 10. So it is low intermediate. Now how do we do it? So this is how we do it. So we'll repeat in low intermediate after 48 hours. In low risk, we repeat after 3 to 5 days. In high risk, we will repeat after 48 hours. So this patient ideally, whenever he is falling high intermediate and high risk zone, we are not going to discharge him. So thanks a lot. These are the beautiful butterflies I have clicked from around. So if you appreciate the nature around, small things make this world very beautiful. Thanks a lot. Thank you.
पल्लवी मॅडम अनम्यूट करा सर्वांना.
Sir. Madam, I was not on the mute mode. Yeah, thank you so much, Dr. Amit, for such an excellent presentation on your topic of hemolytic jaundice. Now, I call upon Dr. Amit Dahat, sir, from Nagpur, who has his presentation on jaundice in preterm neonates. We will take the questions at the end of all the 3 speakers session. Okay. And please put the questions in the chat box, all the audience.
Good evening, everyone. Am I audible, ma'am?
Yes. Your slides.
Okay. Yeah, slides are visible?
Yes.
Yes, sir, slides are visible.
Okay.
Yes.
So yeah, good evening, everyone. I am very much thankful to Maha IIP for giving me this opportunity. I feel really privileged and honored to be part of such a healthy group academically. From one Dr. Amit Tagare to another Amit, right from the 2 corners of Maharashtra. So this diversity, and we are united by Dr. Deshmukh sir, who is like a godfather in the field of neonatology. And when the organizers, they approached me about this topic, they said, like, we don't want this routine academic this thing, we want a clinical flair to it. So here we are. I thought of making this topic as simple as possible and give it a little bit of clinical touch. So if you can see the background of the slide, everything is yellow. Yellow is the today's flavor and the color. And we will see little bit I had gone into about preterm jaundice as well as term jaundice, because that was initially was decided. Wait a second. Yeah. So coming with today's first case, there is a 6-day-old baby. He was bottle-fed baby because that's the culture which nowadays most of the modern families they are adopting. And the parents, they were anxious and they started complaining that the baby is having poor appetite. On the first instance, because the child was not getting proper breastfeeding, they shifted to bottle, and the baby had a little bit of jaundice. The baby was a little bit dehydrated. The temperature was good. The vitals were thin. And this is an open question to all the audience. You can drop the answers in the chat box. That what is your next most important diagnostic criteria that you want to do in this baby? The options are like, bilirubin level, lumbar puncture, CRP, CBC. After listening to Dr. Amit Tagare's talk, you can think about retic count, because once we start diagnosing things and we get fond of repeating those tests, then someone thought of thyroid, some thought there is no need of any investigation, just and follow up after 24 hours. So it's a subjective thing, but to remove this subjectivity, we develop some objective criteria, and we are really proud, Dr. Bhutani from he had done so many pioneer work in neonatal hyperbilirubinemia that the whole world is following him. So if we take an outline of today's presentation, the hyperbilirubinemia is basically excessive level of accumulated bilirubin in the blood, and it is characterized by jaundice. So there are certain things that we will discuss, which are already some of the things, my job is made easier by my previous presenter, Dr. Deshmukh sir, who had given you a brief outlook. Why screening? What is the relationship between the peak bilirubin level and neurodevelopmental outcomes? To screen or not to screen, Dr. Deshmukh sir had mentioned about universal screening, which is their protocol in some of the Western world. Then what is the impact of gestational age? Is jaundice is the same in term baby and preterm baby, and the clinical assessment part and the management part. So if we see neonatal jaundice, so it is nothing but discussion of skin and sclera. It's due to elevated level of bilirubin, and it's get accumulated in the skin and the mucous membrane. And if the serum bilirubin levels are more than 5 milligram per deciliter in neonates, it is clinically apparent. So it is nothing but when the rate of production exceeds elimination, the end result is hyperbil. So almost 60% of the term baby and 80% of the preterm baby at some point of life, they have jaundice level more than 5 milligram per deciliter, and they present with clinical features. And recent evidence-based, they have shown there is a relationship between the peak of jaundice and the development of kernicterus. So it seems simple, but it is a preventable thing. So if we classify jaundice, it can be physiologic one and or the pathologic one. Dr. Jagai sir had spoken about the pathologic jaundice, which is usually present within 24 hours of life. The physiological one, in which more I'll be talking about, it presents at around 4th to 5th day of life, and in 7th day in preterm. And after 14 days, it is clinically not detectable. It disappears within 24 hours. If we see the causes of physiological jaundice, it can be roughly distributed into 4 different pathology. Increased bilirubin load due to physiological increased RBC mass. The RBC lifespan is less. Then there is decreased immediate postnatal bilirubin uptake due to reduced liganding activity. Then hepatic enzyme immaturity for bilirubin conjugation, and increased intrahepatic circulation. These are the main causes of physiological jaundice. And not going into this busy slide, it is the 4 mechanisms which I discussed. It has broken down into detail this thing. If we distribute it into according to the age of presentation. So in the first 24 hours, that is pathology, mostly the hemolytic disease of the newborn, the infection torch, disease period, they present within 24 hours. If we see it in 24 to 72 hours, it's mostly physiological or maybe due to sepsis or polycythemia, due to hemolysis, increase in intrahepatic circulation. If it is presenting after 72 hours, it can be due to sepsis, phelometoma, neonatal hepatitis, and some metabolic disorders, which Dr. Sandeep Kadam sir will be discussing later. So if we see the causes of pathological jaundice, it can be due to excessive hemolysis, defective conjugation, breast milk jaundice, increased intrahepatic circulation, and metabolic and endocrine disorders. So the $1,000,000 question, like, in a developing world, whether we should screen or we should not screen. Well, the American Academy of Family Physician, they say, like, we should have a judicious approach. Either it should be universal or risk-based pre-discharge screening, and that model can be applied in most of the modern setups in Indian this thing as well. That we do risk-based screening. The benefit of screening, obviously, it includes prevention of acute bilirubin encephalopathy, and thus reduces the morbidity and adverse neurodevelopmental outcomes. But if we see, every coin has two sides. If universal screening is blanket everywhere, then maybe, like, there are frequent inappropriate use of phototherapy. The phototherapy abuse can increase, which is a big problem, especially in a resource limited country like India. So we need to allocate our resources very wisely. And there is lack of evidence that screening of neonatal hyperbil, it reduces the occurrence of chronic bilirubin encephalopathy. But still, that's why the middle path, risk-based screening, should be applied. So what is this bind score? Like, bilirubin induced neurological damage. So neonate with severe hyperbil, they are at risk of bind. And for every baby, the threshold at which the baby can develop connectors, it can be different. There are many factors which collaborate, like, in developing connectors, induced neurological damage. And bilirubin neurotoxicity, in acute cases, it manifests as acute bilirubin encephalopathy. So what is the standard screening protocol in Indian setup? So the recommendation is healthcare professionals, they should all look for jaundice in their daily rounds, visual inspection. We should assess all newborns for jaundice every 12 hourly, especially in the initial 3 to 5 days. And we should monitor for development of severe jaundice, and we should be careful, like, that they should not land up with connectors. We should be particularly careful in babies who are having any risk factors. So there is a mnemonic which goes with the name of jaundice, which was mentioned in our AIMS protocol as well. So a baby who is having jaundice within first 24 hours of life, or having a sibling or unrecognized hemolysis, non-optimal sucking or nursing, deficiency of G6PD, infection, cephalometoma, or particular tribes in which, there are more chances that the baby might develop jaundice, so we need to be a little bit aggressive and more on the, more on our toes to screen those babies. So what is the algorithm that we have designed? Like, the crux of the story is we should perform visual assessment every 12 hours during initial 3 to 5 days of life. And visual assessment can be supplemented with transcutaneous bilirubinometer, which is now available in most of the even centers in India. So first of all, you need to decide whether the baby is having serious jaundice or not. If the answer is yes, you think the baby is having serious jaundice, then immediately start phototherapy. After that, measure bilirubin level and determine if the baby requires phototherapy on exchange transfusion by plotting it on Bhutanese nomogram or AP bilirubin charts. If you feel the baby is not having serious jaundice, then decide whether the baby is having significant jaundice to require TSB measurement. If the answer is yes, then measure TSB level and determine according to nomograms. If the answer is no, then go for the observatory study and repeat every 12 to 24 hourly. So the essential step in screening is examine the baby in bright natural light, blanch the skin or look in the sclera. Determine the degree of yellowness, that's an important indicator of level of jaundice, and a deep yellow is often associated with severe jaundice. So bilirubin measurement can be done with total bilirubin levels or transcutaneous bilirubinometer. So what are the indications for bilirubin measurement? if any jaundice is appearing in the 24 hours, any pathological jaundice, you need to go for a bilirubin measurement. There is no other option. Beyond 24 hours, if visually assessed, then you can think about, if you are unsure about your visual assessment, then you should go for a bilirubin measurement. Or during phototherapy, at that time, your transcript to this bilirubin, there is high chances you get an erratic result. So, or in selected cases of rebound. So these all are indications for bilirubin measurement. What are the clinical pointers for assessment of neonatal hyperbil? First of all, you should think about what is the maternal blood group, and if a mother has not had prenatal blood groupings or Rh negative status is not known, then we should go for a blood type of fetus, as well as cord blood are strongly recommended. We should not use the albumin bilirubin ratio while making decisions about the management of hyperbil. And these are the certain risk factors and the assessment guide. So all the newborns they should undergo a complete clinical examination, evaluate for the intensity of the jaundice, breastfeeding adiposity, is there any cephalohematoma or swelling any over, or any occult blood loss that has happened. Evaluate for lethargy, general activity and the tone, look for splenomegaly, for padding and pallor. So any clinical assessment, you should always start with history. Look at the gestational age, the feeding history, but the birth history, asphyxiated babies, already the neurological insult is there. So those babies, they are even more prone for damage caused by the connectors. If there is any family history of splenectomy or jaundice, the urine color, the stool color. So everything need to be assessed in a stepwise manner. Then by the tremor staging, you can assess the severity of the jaundice, look for any signs of dehydration. There was very interesting cases which we come across, the babies, they are in the borderline zone of exchange transfusion, maybe with slight correction of dehydration. The jaundice, it falls rapidly. Then look for any abdominal mass or hepatosplenomegaly. So this is what a tremor staging it looks like. Based upon the dermal zones, if the jaundice is still toe, then the baby is in high risk, that may require exchange transfusion. So for the baby who is receiving phototherapy, we need to see the bilirubin, the blood type, the DCT, G6PD status, PFS, retic count. And the baby is presenting beyond third week of life. Dr. Sandeep Kadam sir will be talking more about in detail. So the thyroid and galactosemia and uterine routine we should do. So how accurate is this transcutaneous bilirubin? With the advances in science, nowadays, more and more we are moving towards screening and non-invasive investigations. So the routine employment of transcutaneous bilirubin can reduce the need of baby sampling by almost 30%. These are the studies, but at the actual figure, they are even more, especially in a high volume centers. Then transcutaneous bilirubin, it becomes unreliable once the bilirubin level goes beyond 14. So as I had mentioned, in pathological jaundice, it's always better to have a serum bilirubin also. Our specific transfer for prediction of subsequent bilirubin is useful, and the trends in TCB values by measuring 12 apart would have a better predictive value than a single crossover value. So these are the normograms which are already been discussed. So I'm not going into much detail about it. So there are different charts for babies, for the term babies as well as preterm babies. So in the preterm babies, this is a recent article which is published by Dr. Bhutani, and he had given us a rough guideline, based upon the gestational age, when we should initiate the phototherapy. So there is another concept of prophylactic phototherapy in extremely low birth weight and extreme premature babies. So, but still, that's still a gray zone. Every unit, they follow their own charts and protocol. So, but this is what the recent guidelines which I had came across. So, in a baby who is less than 28 weeks, the bilirubin level more than 5, it warrants phototherapy. As the gestation age increases, the value also like increases, and these are the chart which we had adapted. It was published, and it gives a rough outlook, like that what is the phototherapy range and what is the exchange transfusion then in a premature babies based upon their gestation, like in less than 28 weeks, and as the age progresses the value also, like and the same chart is converted in the table format, so we can see, like for a baby who is less than 28 weeks, or even a bilirubin of, like 11 to 14, it's a cutoff for exchange transfusion. But as, like they are more vulnerable, and like at relatively lower bilirubin levels also, they develop a severe cerebral palsy. So, like we need to be really aggressive in giving phototherapies in these premise, because right now the motive of our care is changing from just survival care to the quality care. And in the timing of follow-up, like it depends upon the length of stay in the nursery, presence, absence of risk factors for hyperbill, and any other like risk of neonatal problems. So earlier, close and more frequent follow-up should be provided for those who have risk factors for hyperbill. So if the infant is discharged before 24 hours, then they should be seen at least, like in the next 48 hours. If the baby is discharged between 24 to 48 hours, then maybe at 96 hours. And if the baby is discharged between 48 to 72 hours, then maybe at 120 hours. So as I'd already mentioned, the preemies, they have more incidence of severe cerebral palsy. There are certain studies which had shown, like they had more psychomotor impaired development, and more hearing impairment. So the preterm babies with congruent illness, like sepsis and HMD, and the physiological derangement, they are more vulnerable to bilirubin neurotoxicity. It can even lead to neonatal death and multisystem acute manifestation, long-term impairments, and the ictic complications are exceedingly due to prophylactic and effective use of phototherapy, which I had mentioned. It's becoming less and less evident. So what are the clinical pointers to a supportive care in neonatal hyperbill? Like, all women, they should be encouraged for breastfeed at least 8 to 12 times a day. Supplementation is not routinely recommended. It's recommended only for dehydrated newborns where weight loss is more than 10%. Express breast milk is obviously the most preferred supplementation. Routine supplementation with IV fluids is not recommended. And the breastfeeding, as far as possible, should not be interrupted unless the baby is requiring very aggressive phototherapy and, like in the exchange transfusion zone. So these are the take-home messages, the AP guidelines, which says, like we should promote and practice successful breastfeeding, establish nursery protocols for the identification and evaluation of hyperbill, measure the bilirubin or the transferred bilirubin level infant jaundice in the first 24 hours of life, recognize the visual estimation of the degree of jaundice. And in the dark babies, it can be, like a little bit challenging, but in that case also, like we should go for serum bilirubin. Interpret all bilirubin levels according to infant's age in hours, which was stressed by Dr. Amit sir. Like in jaundice, we don't talk in days, we talk in hours. And the gestation age is also, like another important factors which determine our further course of management. Provide parents with written and verbal information about newborn jaundice. As we know, like it's what's the observation of one nursing staff that had, like brought the use of sunlight, and which is in our India there is custom, like of sun bath given to the baby. And we should treat newborns when indicated with phototherapy or exchange transfusion. So with that, I know we are running a little bit short of time, so I try to wrap up in as early as possible. So the take-home message, what we can say: trust your clinical judgment, follow the norms, and in the premature babies, be aggressive, like in starting the phototherapy. So I'm once again thankful to the organizers for giving me this platform. So over to Dr. Renu ma'am.
Yeah, thank you so much, Dr. Amit, for your excellent presentation on jaundice in neonates. Now we will move over to the next speaker, Dr. Sandeep Kadam, sir. His topic is prolonged jaundice. Welcome, sir.
Good evening, everyone. I'll just share my slides.
Yeah.
Good evening, everyone. At the outset, I would like to take this opportunity to thank Dr. Gangolia sir, Dr. Mohite sir, and all the office bearers of the Maharashtra State IAP, and also Deshmukh sir for being a good, being a moderator. So with that Amit Square having presented neonatal jaundice in the initial first few days of life, and Amit Dahat presented the physiological and the factors which are going to exacerbate hyperbilirubinemia. We come to the next part of our discussion, that is what is prolonged jaundice and how do we deal with a newborn who presents with prolonged jaundice. So by definition, any baby who has a bilirubin more than 5 milligram per deciliter is pathological jaundice after 2 weeks of life. If the direct fraction is more than 15 to 20% of the total bilirubin, then we would say that this is conjugated jaundice or direct hyperbilirubinemia. When do we say that jaundice is prolonged? If it is more than 2 weeks in a full-term baby, and if the jaundice is persistent more than 3 weeks in a preterm baby, then it is pathological, and then this would be labeled as a baby with prolonged jaundice or prolonged hyperbilirubinemia. Now let us go to the first case. This is a term baby, male child, weighing 3.2 kilos at birth. This baby was brought on day 16 of life with yellowish discoloration. The mother said that the baby was looking yellow, the eyes are yellow, and the skin was looking yellow, especially in the evening hours. This baby was exclusively breastfed. The weight on day 16 was 3.5 kilos. So there was a weight gain of 300 grams. Obviously, the baby would have lost some weight in the first 10 days of life. Thereafter, the baby started putting on some weight. The urine color was normal and it was not staining the diaper. And she very categorically told us that the stools are yellow and the baby is passing stools 3 to 4 times a day. Urine output was 7 to 8 times a day, suggesting probably that the mother has enough milk and the baby was feeding well. So what does one do when you see a baby with prolonged jaundice on day 16 in such a scenario which appears that this most likely would be unconjugated or indirect hyperbilirubinemia, the reason being that the urine was not staining the diaper. So on clinical assessment, this was a term baby, a well-looking, comfortable baby in the mother's lap. There was no pallor, but there was jaundice. Icterus was present. There was no facial dysmorphism. The eyes and the ears were normal. The head, spine, and the genitals were normal. There was no hepatosplenomegaly. There was no obvious murmur which was heard in the cardiovascular system. So the impression in this case was a prolonged jaundice in a term baby who was apparently a well-looking newborn. So obviously it tells me that this was a baby who is otherwise well but looking yellow. So what next? We asked for some basic tests in the form of hemogram, peripheral blood smear, bilirubin, and thyroid. Hemoglobin was 13.2 with total counts of 8,400. Peripheral blood smear, there was no hemolysis. Serum bilirubin was 18.5 milligram percent. T4 and TSH were normal. So obviously, what is the role of phototherapy? Because when you see a baby with a bilirubin of 18.5, question that one would obviously get is whether we should put this baby under phototherapy. Now here in this case, if you see the Bhutanese nomograms which both the Amits showed, they categorically would say that it is from day 0 hours of life to about 7 days. And thereafter, the bilirubin, if it is more than 18, one would give phototherapy. It's again a very gray area when to stop phototherapy. But by and large, if the bilirubin is less than 15, one would definitely stop phototherapy, irrespective of the reason. Now, here in this case, the bilirubin was 18, so baby might require phototherapy. So the next question is this breast milk jaundice? And obviously the first diagnosis that comes to our mind is that any well baby who is feeding well apparently comes after 2 to 3 weeks with yellowish discoloration. There is no blood group incompatibility. There is no hepatosplenomegaly. There is no hemolysis. There is no obvious infection. My diagnosis is breast milk jaundice. And that's what we would probably come and think. The next question is, will you stop breastfeeding and start formula feeds for about 48 to 72 hours, which has been a dictum to practice in our day-to-day practice? The answer to both these questions is no, because breast milk jaundice is a diagnosis of exclusion and there is no role of stopping breastfeeding and starting formula. Please continue mother's own milk. So I think we all probably would go home with a message that don't label any prolonged jaundice as breast milk jaundice, because it is a diagnosis of exclusion and not inclusion. So in this case, phototherapy was started. We sent a urine culture and the urine gave Klebsiella, which was sensitive to amikacin. Baby received amikacin for about 10 days and the repeat urine culture was negative. Ultrasound was asked because basically the baby had a symptomatic UTI, in this case with hyperbilirubinemia. And there were kidney size were normal, but there was residual urine between the pre and the post void test. And this again tells us that this residual urine could be a source of an occult UTI presenting as hyperbilirubinemia. We did a MCU which showed grade 4 reflux on both the sides. Cystoscopy was done and it showed posterior urethral valves which were fulgurated. The baby was discharged on cotrimoxazole prophylaxis. Follow-up bilirubin at 6 weeks was 0.6 milligram per deciliter. So what did we learn? This was a case of prolonged neonatal jaundice, unconjugated, secondary to urinary infection. And in this particular situation, the baby had valves. So whenever you see a baby with prolonged neonatal hyperbilirubinemia, which is unconjugated, I think these are few carry home messages that we would remember. Look for hypothyroid. And we, in today's time and era, we are doing newborn screening. So most of the hypothyroids are getting screened on day 1 in the form of TSH. But if you see a baby with prolonged jaundice beyond 2 weeks in a term or beyond 3 weeks in a preterm, look for occult infections, and urinary tract infection is very common. Look for fungal infections, especially in the setting of a baby who is extremely small and admitted in the NICUs, received multiple antibiotics, received TPN, has got long lines, has received steroids. This could be a baby with fungemia, which can present initially with unconjugated and later with conjugated jaundice. So always remember that fungal sepsis is something which can just present as prolonged jaundice, initially unconjugated and later conjugated. Galactosemia similarly can present with unconjugated initially and later on with liver disease and conjugated hyperbile. Look for low-grade hemolysis, and the peripheral blood smear and a reticulocyte count will give us a good clue that there is a hemolysis going on. The hemoglobin is falling and the bilirubin is not coming down. So this could be a G6PD or a hereditary spherocytosis. Mind well, once in a while, you may have a familial unconjugated non-hemolytic hyperbilirubinemia, such as Krigler-Najjar 1, 2, or Gilbert syndrome. So these are rare, but if you have a history of familial jaundice, please don't forget to look for these conditions. And once in a while, one would see such a baby with familial jaundice. Apart from that, if you see a familial jaundice, it could be autoimmune hemolysis. And to conclude, any baby with prolonged unconjugated jaundice, breast milk jaundice is a diagnosis of exclusion and not inclusion. So once you have ruled out all these, then one would label that this could be breast milk jaundice, wherein you just have to reassure the mother that you continue breastfeeding. There is no reason to stop breastfeeding. Don't give formula feeding. There is no need to give supplemental milk unless the mother is showing signs of lactation inadequacy. Otherwise, into breast milk jaundice, please continue breastfeeding. Now we're going to go to the second part of our discussion, and that is a newborn with prolonged jaundice. And obviously one would see that this could be a baby with cholestasis. Now this was a term baby who presented on day 27, female child. Birth weight was 2.2 kilos. So this was a low birth weight baby. And now the baby presently is 2.9 kilos. And the mother has brought the baby with yellowish discoloration of the eyes and urine which is staining the diaper. Stools are yellow. So obviously from this history itself, we get a clue that this urine is staining the diaper, there is icterus which is present. So we are probably looking at a conjugated jaundice or a direct hyperbilirubinemia. This was a non-consanguineous marriage, first child, feeding well, and obviously the baby had shown some weight gain. It was a normal delivery. Baby had cried immediately after birth. Baby was admitted in the NICU initially for 2 days with hypoglycemia, requiring IV fluids, but no TPN. So this baby was given some IV for transitional hypoglycemia, and thereafter the baby recovered well. Obviously, probably it appears that this hypoglycemia could be because of a low birth weight status, since the weight was 2.2 kilos. So what are the problems? There is neonatal jaundice, and this is probably a conjugated hyperbilirubinemia. Clinically, this baby was 2.8 kilos. There was no pallor. There is icterus, which was lemon yellow in color. The eyes and the ears were normal. There was no facial dysmorphism. So the baby was absolutely looking well. Abdomen was soft. Liver was 3 centimeters firm. Spleen was 2 centimeters palpable. There was no free fluid. There was no distension, no other lump which was palpable, no free fluid. The cardiovascular and the respiratory system examinations were normal. So impression, this was the day 27 conjugated hyperbilirubinemia, which we are looking at. So what would be the approach that one would do in office practice or even in a NICU is to look at the basic test, and one would see do a hemogram to see if there is any anemia, thrombocytopenia, wherein you would try to figure out if there is hemolysis which is going on, which is causing initially unconjugated and later on conjugated, like an inspissated bile syndrome, or it could be a torch infection if you have anemia, thrombocytopenia, leukopenia, neutropenia. You could look at urinary bile salts and bile pigment which were present in this case, suggesting that this is a conjugated jaundice. One would definitely do a complete liver function test, including a prothrombin time, thyroid to look for hypothyroidism. Ultrasound abdomen, especially done by a trained sonologist, would look at the liver, but most important to see the size of the gallbladder, if the gallbladder is full or collapsed. In a fasting state, if the gallbladder is full and it is showing that this is contracting after feeding, you have with some confidence to say that this is unlikely to be biliary atresia. A fundoscopy would definitely help for chorioretinitis or cherry red spots. An ultrasound brain for any ventriculomegaly and calcifications to look for torch infections. So these are basic tests that I think we would all agree to do in a baby with prolonged jaundice or conjugated hyperbilirubinemia in our office practice. This baby had a normal hemogram, thyroid functions were normal. Liver functions done showed SGPT of 165, total bilirubin of 6.4, and the direct fraction was 5.2. Again, telling us that our impression of conjugated jaundice was confirmed biochemically. The prothrombin time was prolonged, 21 for a control of 14 seconds. Gamma GT was not high, it was normal, 84 milligram per deciliter. Now, again, telling us that if the gamma GT is high, it goes in favor of intrahepatic biliary obstruction, wherein a biliary atresia or a biliary stagnancy would give us a very high gamma GT levels. Ultrasound brain was normal. There were no calcifications. USG abdomen showed full gallbladder, normal ecotexture of the liver, and hepatomegaly and splenomegaly. Now, this probably tells us that we are not looking at a surgical cause of neonatal jaundice, but more likely to be a medical cause of a neonatal jaundice. So our clinical impression is neonatal hepatitis. In view of this, baby being low birth weight, we would look for congenital infections. Some clinical markers on our clinical assessment which points towards a torch group of infections could be a baby having small head, microcephaly, or a large head, or a small head with ventriculomegaly, cataract, rashes. Then you may have blueberry muffins, chorioretinitis, petechiae, and chorioamnionitis and placentitis and velitis on histopathology of placental examination. One would do a serology, but has very minimal benefits. But one could definitely look at doing a PCR, especially for CMV. And now in this case, the urine CMV was positive. So urine CMV PCR was positive, suggesting that this was probably a congenital cytomegaloviral infection with hepatitis, which could be associated with low birth weight status. Baby was initiated on valganciclovir at a dose of 16 milligram per kilo per dose twice a day. Baby showed good weight gain, and a BERA was planned at 3 months. Now, Here in this case, a BERA is of utmost importance because CMV can cause hearing impairment and chorioretinitis. So whenever you see a baby with conjugated jaundice or direct hyperbilirubinemia in first month of life, first month in the sense first 4 weeks, please look for congenital infections. Please look for neonatal infections in the NICU. Now, this could be our gift to the baby, wherein there could be nosocomial sepsis, and nosocomial sepsis is a very deadly condition, especially gram-negative, which organisms which can present initially as indirect jaundice and later on as conjugated jaundice. So sepsis-induced cholestasis, often these babies are NBM, they may receive TPN, they may have long lines, they may have fungal infections in addition to a gram-negative sepsis. So all these predisposes a baby for cholestatic jaundice. Extreme prematurity, long NICU stay, prolonged parenteral nutrition, multiple antibiotics, all these predisposes for sepsis and PNAC, that is parenteral nutrition associated cholestasis. You may have a severe Rh isoimmunization presenting as severe hemolysis, or you may have ABO incompatibility or G6PD, which can present as hemolysis, anemia, and a very high indirect jaundice, which initially is indirect, but later on it may present as conjugated or a direct jaundice because of inspissated bile syndrome. So always remember, if you have an inspissated bile syndrome or a cholestatic jaundice with normal liver function and anemia, look for hemolysis. You may have a cholestasis with low gamma GT. In this case, this is progressive familial intrahepatic cholestasis or PFIC, which is again familial cause of neonatal hyperbilirubinemia. So some clinical clues to cholestasis. If you see a baby with cholestasis and dysmorphism, look for trisomies, especially Down syndrome, Alagille syndrome. If you have a baby with midline defects and cholestasis, hypopituitarism and septoptic dysplasias. A baby with cataract and jaundice, look for galactosemia. You may have fructose intolerance or torch infections. A baby who presents with cholestasis and hypoglycemia, look for galactosemia, tyrosinemia, sometimes glycogen storage, fatty acid oxidation defects, and mitochondrial diseases. So these are some of these rare conditions which may have hypoglycemia with cholestasis. So I think with this, I'll be happy to take some questions if there are any.
Yes, sir, we can take it at the end of Dr. Deshmukh's comments. Yeah.
Thank you very much.
Thank you, Dr. Kadam, sir, for your excellent presentation on prolonged jaundice. Now, I request Dr. L.S. Deshmukh, sir, to give his inputs on the last 3 topics of the speakers. Over to you, Deshmukh, sir.
Thank you all the 3 speakers for excellent presentations. I think most of the aspects related to neonatal jaundice, including direct jaundice, have been covered adequately by all 3 faculties in the time given. And mostly they had made it a case-based presentation, so I appreciate that. And apart from these things which they covered, there are a few things I just want to add or say. One is physiological jaundice. That is a misnomer. I guess the term should be developmental jaundice and not physiological jaundice, because it is always a combination of various mechanisms and factors. Because a physiological has so much of variability. We compare a preterm baby versus a term baby or the day of life. The levels are variable. Because the physiological, once you label it as a physiological jaundice, you are relaxed and you are not going to intervene, not going to follow that baby closely. So it should be ideally replaced by developmental jaundice. Secondly, we have to remember that in India, for various reasons, the incidence of severe hyperbilirubinemia or even kernicterus is high. We do not know the exact burden of bilirubin encephalopathy in our population. We are missing so many of them. We are losing to follow-up. Many of them, they are dying after discharge. That may be related to maybe some inherent genetic or racial factors in Indian population. And there is a widespread practice of exclusive breastfeeding in India. But this exclusive breastfeeding is not adequately counseled when the mothers are exclusively breastfeeding. They are not looked at whether there is a adequate breastfeeding, whether there is any significant weight loss. For this, we need to follow this baby. So healthy baby which is discharged needs to be followed up very closely. What happens is Baby is delivered term, healthy, vaginal delivery, baby cried well with mother. Baby is immunized day 1, discharged next day. And then they are coming on day 5, day 6, day 7. If they notice the jaundice, before that they may come. But by that time, most of the times it is late and they come with a lot of other problems. And mind you, I have always faced problems in babies who are in the postnatal wards with the mothers. They are term babies or late preterms because there are weight criteria in many of the public hospitals, even in private, but they are not mature enough. They may be having the weight criteria of not being admitted in NICUs, but they are late preterms. And these babies can be very particularly very problematic. These babies are not feeding well, not feeding adequately. On the top of that, some of the mothers are priming, some of the mothers have undergone cesarean section. So these babies we have always found problematic and they come on day 2, day 3 with lethargy, hypoglycemia, dehydration. They are readmitted with severe hyperbilirubinemia and a lot of other problems. Then secondly, in India, we know the temperatures, they go very high. And now already the summer has started. And we find that problem particularly in summer. The levels of bilirubin are higher in all the babies in summer in our hospital. But this is creating a lot of problem. Not only there is a dehydration fever and associated dyselectrolytemia, but there is a severe hyperbilirubinemia, hypoglycemia, and so many other problems. So that has to be taken care of. And another thing which I highlighted in the initial thing also, in mothers who are O positive, the obstetricians themselves, they should be educated if you are attending pediatrician, or you should be following those babies, if the baby is A or B, very closely. They may not initially show significant jaundice, but it can subsequently increase. And another thing is in India is an infections. Initially, they can be low-grade infections, which can become as fulminant sepsis. And then they present with a lot of problems. And on the top of that, there are multiple advisors in India. There are so many doctors. It's not just MBBS or pediatricians, or there are family members, immediate family members. There is a practice of keeping the baby in the sunlight if it is yellow and not going to the doctor. Sunlight works, but sunlight works under different conditions. Where it is phototherapy is not available, you may go for sunlight. But again, the sunlight has to be filtered light and all those things are there. It is not a very intensive phototherapy kind of. It may be a standard phototherapy where babies are stable and there is a low-grade hyperbilirubinemia. Another important problem which we face in public hospitals, maybe in private also you are facing, the 3 delays, which I always tell my resident, look at these 3 delays. The first delay is delay in seeking the care. Because jaundice, पीलिया तो होता है, सबको क्या करना है, बैठो घर में. So they are not decided to go to the pediatrician. Seeking the care is delayed. Second is, if they decide at all to go to the hospital, is going to the hospital, how to reach? They are in the peripheries, in the villages, some distances. Transport is a big problem. There is no organized transport in India. So they come by all sorts of means. They come by auto rickshaws and kali pili and all those things. And they, by the time they reach our hospital, it is too late. Another important thing is once they reach the hospital, I mean, that delay we cannot address in a busy public hospital. They reach our casualty and they are lying there for 2 hours. They are searching initially where is the casualty. They reach the casualty and then they are sitting there for 2 hours. So by the time the baby reaches our ward, is dehydrated, not feeding well, not being fed for 3-4 hours during transport. At the hospital, baby is hypoglycemic. So it becomes a very bad situation. Another thing is, once they reach the hospital, it is applicable to even the private hospitals, not all. Are we giving the quality care which is desired? Quality care doesn't mean that some glitterati and this machines and everything. Are we giving effective, timely, efficient care? I mean, in case of hyperbilirubinemia, it could be effective phototherapy. Are we using effective? What is effective phototherapy? Now, even today, many of the pediatricians are using white tube lights, fluorescent tube lights, which do not give lot of irradiance. It's a standard phototherapy units they are called. So they deliver around 8 to 10 irradiance, which is a standard phototherapy. But mind you, in today's era, we need to go for intensive phototherapy whenever phototherapy is indicated. So that means the irradiance has to be more than 30, and that can be adequately delivered by present day. Most of the phototherapy units are LED blue light, special blue phototherapy units. So they can be purchased, not very costly. I won't ask many pediatricians which are in the smaller units to replace the older units, but see that in babies who are at risk of severe hyperbilirubinemia, you give intensive phototherapy. And always assess the baby at the time of discharge, or if you are an attending pediatrician for severe risk factors for severe hyperbilirubinemia. You have to differentiate between risk factors for severe hyperbilirubinemia and the risk factors for phototherapy or exchange. These two different graphs are there. And you must make a habit of following some graph, some guideline, which the speakers have already told. Bhutani nomogram we are using, and the Bhutani nomogram, remind you, this is not used, this hourly specific chart is not used for deciding whether to give phototherapy or exchange. It is not. It is for evaluation, categorization, and deciding how frequently we are going to monitor these babies after discharge. And phototherapy and exchange, of course, those have been shown, they should be used. Another thing is, in babies who are presenting more than 2 weeks, after 2 weeks, with a persistent jaundice, as Sandeep has highlighted it very well, very clearly in his presentation, we should not be missing the direct jaundice. So always we need to ask what is the color of urine and what is the color of stool. Is urine colorless? Is stool pigmented? That means there is no obstruction. If the urine is colored and there is no obstruction and no direct jaundice. If urine is dark colored and the stool is pale, it's a danger sign. Earlier you pick up this biliary atresia, better it is. It should be picked up less than 6 weeks so for better success of Kasai operation. And again, mind you, not all these patients will go for Kasai operation. And the Kasai operation is not successful in most of all these babies. There are variable results. And again, even if it is successful, mind you that we need to prepare that family, that baby for not only Kasai, but subsequent liver transplant. Because Kasai is going to just buy you time. Eventually, most of the babies will land up with liver failure and they will need hepatic transplant. So with all these things in mind, and as Amit was saying about these transcutaneous bilirubinometers, I mean, there are of course some other various makes are there, but if you purchase a good one, it will be costing around say 2 lakh, 180 to 2 lakh. So that is good one, and they are now quite predictable. There are separate charts also for TCB. AIMS has published those charts for TCB values also. So you can judge yourself by monitoring few babies with TCB and simultaneously doing TSB, and judge yourself what is the accuracy of your machine. And by that way, you can decide how we are going to follow that baby, how we are going to evaluate the baby. So it is an useful tool. And eventually, I think we will be shifting to TCB as a screening model. So these are the few things I need to say about this today's excellent case presentations by all three faculties. Thank you once again.
Yeah, thank you, Deshmukh sir, for your expert advice. Now there are a few questions in the chat box. First, I will be asking Dr. Amit Tagare. One of the person a doctor has asked why all Rh negative mothers baby do not develop pathological jaundice.
It all depends on the exposure. So it is as we know that what we do in an Rh negative mother who is exposed to Rh positive baby is we administer 300 micrograms of the anti-D. Now, how come this 300 microgram came? That is because we assume that there is around 30 to 100 ml of fetal blood bleeding into the maternal system. Now, it is all depending on the exposure that the mother gets. So, if the mother is getting higher exposure, she will get a higher response. So, even with a proper anti-D administration, sometimes these mothers get exposed and they develop this response. So it all depends on, it depends on two things. One is the exposure to mother, and the second thing is how much fetal and neonatal RBCs are bound, and that stimulate the macrophages. So that is how we always say in first pregnancy, no risk, in second pregnancy, 3%, in third pregnancy, 10%. All these because as the pregnancy advances, the maternal response becomes stronger and the higher exposure will happen.
Okay. What is triple surface phototherapy?
See, it is all nuisance.
Okay.
Triple, single, double, triple, quadruple. It is intensive phototherapy. If you give one phototherapy which gives 30 to 50, that is good enough. You put 4 to 5 irradiance, 3, 4 phototherapies combined, it won't become intensive phototherapy. The basic idea is giving a proper dose and exposing the highest surface area. So you want to expose the maximum surface area of the baby. And the phototherapy to be effective should be as close as possible to the baby. These LED phototherapies are non-hitting phototherapies, so it becomes as close as possible. So higher dose, higher intensity, and maximum exposure. It doesn't mean how many phototherapies you use. You have to increase the dose. So what you can do, you can apply the aluminum foils around. You can put the white sheets, which will be more reflective. So the maximum phototherapy dose is delivered to the baby. No single, no double, no triple, nothing.
Okay. One of the doctors asked how many patients treated with IVIG needed packed cell volume transfusion on follow-up.
If we read the meta-analysis, ideally it doesn't increase the risk if it is given in the first 12 hours. In later 12 hours, there is some increase in the transfusion. Now, I have not actually documented my patients, but it is around 10 to 20% patients definitely need transfusion, and it is variable. Somebody needs in second week, somebody needs in first week, somebody needs in third, fourth, fifth week. So the only thing is we have to keep in mind that we have to monitor, and it is not just the hemoglobin, we have to monitor their ferritin and iron. So we have to decide the time when we want to shift from folic acid supplementation to iron supplementation. So if we are getting consecutive reports where hemoglobin is not falling, that is safe, where you can increase the time difference between the next checkup.
Okay. The dose of IVIG 1 gram or 2 gram per kg?
2 gram per kg.
Okay, thank you, sir, for your kind answers. Over to Dr. Amit Dahat, sir. There are a few questions for you. If TCB has so much shortfalls, is it really worth it to do?
Well, the answer is already been, the question is already been answered by Dr. Deshmukh, sir. Like, you need to decide on your individual unit basis. See, like, if you are in a busy unit, like you are having 100 to 200 babies, like, in your postnatal ward. So it is literally like, difficult, like, to go and investigate each and every baby with serum bilirubin which you are doubting. So it gives you more of a pragmatic viewpoint, like, it's a time saving, non-invasive. The parents are also happy. And if you are, nothing can replace your clinical judgment. So if you are thinking like if this baby is clinically looking this, and you need to cross check your sensitivity of the machine as well. That is also like Dr. Deshmukh sir had clearly said. So based upon that evaluation, you need to decide. So there is not one size of shoe fits all. You need to decide on individual case basis, and based upon that you need to decide. But the era is more moving towards gadgets. They had become an integral part, but still clinical judgment, it supersedes any gadget available in the universe. So I think that answers to the question.
Yeah. Okay, doctor. There is a question: in which situation cord bilirubin should be measured?
Well, like, in any maternal, like, is RH negative mother is there. So it should form your basis of your unit protocol, especially in the high risk, like, suppose if antenatally only, like, if there are any evidence of hemolytic jaundice, any evidence of hydrops, if those are there, then it's always better, like, to have your baseline cord bilirubin, cord blood, this thing. I think Amit sir wants to add anything to it. Yeah.
As Amit said, it is right. High risk patient where we expect immune hemolysis, the cord blood bilirubin level might help, and it is not just cord blood, it's cord hemoglobin also. So if the cord bilirubin level is more than 2.5, it is considered a high risk, and these are the patients where we monitor it more diligently. If it is rising more than 0.5 milligram per hour, this is the patient who is going to land up with trouble. If the cord hemoglobin is less than 11, then it is also once again the risk factor. So that indicates the hemolysis is active in utero. So wherever you have a high risk patient, immune hemolysis risk, previous pregnancies having severe jaundice, that is the patient where we need to check that.
Okay. Dr. Kadam sir, there is a question. In the case you have presented the prolonged jaundice with urosepsis, whether CSF should be done or not?
Well, in all babies with late onset sepsis, one would do lumbar puncture and urine examination and a blood culture, obviously, before giving antibiotics.
Yeah, okay. How to differentiate between chronic RH or ABO incompatibility and breast milk jaundice?
Breast milk jaundice is a diagnosis of exclusion.
Yeah.
And RH or ABO, basically one would look at hemolysis on peripheral blood smear, reticulocytosis. And as Amit had told, I think Coombs test would help us pick up a RH isoimmunization. And Coombs will most of the time be negative in a ABO incompatibility. And that is basically related to expression of A and B antigen apart from RBCs in other extra hemopoietic organs. And the anti-A and anti-B antibodies are incomplete antibodies.
Okay, sir. At 1 month of age, we get a bili of 5. So should we follow up this case? And if so, how frequently?
I think very important to follow up a baby with any bilirubin more than 5. But please look at that conjugated fraction or the direct fraction. If it is more than 15 to 20%, this may be heading for a neonatal cholestasis or a biliary atresia. So one needs to follow up after a week or 10 days and do a complete LFTs with direct fraction of the bilirubin.
Okay, thank you so much. I think all the questions have been answered. Deshmukh sir, do you want to add something?
Madam, there was one question about sunlight, whether it should be given for hyperbilirubinemia.
Okay. Yeah,
and that's obviously telling us sunlight.
Okay. Yeah.
So a lot of people tell to keep the babies
in the sunlight,
under
in
sunlight
the
treating jaundice, and basically that's something which is uncontrolled. There may be some plausible physiological mechanism, but obviously one would not advise sunlight for hyperbilirubinemia for the very reason that there could be sunburns and there could also be ultraviolet rays. So one should just advise feeding and monitoring the hydration, as most of these babies, if they are fed well, the jaundice would disappear and decrease.
Achha, yeah, it was asked in the last, therefore I couldn't see it. Yeah.
Dr. Renu, I have a few questions. Can I ask you?
Sir.
Okay. The exchange or phototherapy cutoffs which you said, are they meant for total bilirubin or unconjugated or conjugated component? So suppose you get at the end of on 15th day something like 25 with 10 of conjugated, will you go for phototherapy?
10. It is total.
Total at any level? It's any.
Yeah, total.
I recall in the olden days we used to say to total you give phototherapy, you'll get bronzing or something like that, right?
So the thing is, it is total. The other important, why we are worried is we are worried about the free fraction. So the free fraction is something that is damaging. So there are two different ways of thinking. There are certain nomograms which calculate the free fraction and accordingly do it. But the most important thing, the nomograms, the AAP nomograms that are usually followed, it is for total. In the conjugate hyperbilirubinemia, when the conjugate factor increases, in that case, it can increase the free fraction because the albumin binding is affected. The third important thing is the medicines that we administer. Now, why we don't like ceftriaxone in neonate? There is something called a delta factor. Delta factor is the capacity of any drug to displace bilirubin from albumin binding. Now, the delta factor, if we check, I think the ceftriaxone delta factor is 3.8. So it has 3.8 times more affinity to albumin compared to bilirubin. So it will make that much of bilirubin free in blood, which can cross the blood-brain barrier. So we have to take all these things in mind. So now when we consider the nomograms, we have to always think about the risk factors in that patient. So bilirubin of 12 may not be risky at that age of life for a normal patient, but can be risky for a sick patient, like a patient of HI. So these things should be considered. But when we calculate the levels in the current nomograms, it is the total bilirubin that we consider.
The second question is, what is the science behind Kramer's index? Like at 15, you have up to abdomen. Beyond that, it's 20. What's exactly science? I understand it's a bilirubin in the blood. Why it should be seen on 10 only in the face and chest, and why at 15 goes to abdomen? What is the science exactly?
It is, Kadam sir wants to answer, or?
It was a study which was done ages ago in a very small group of babies, and they tried to correlate the physical appearance of jaundice, which was seen as a cephalocaudal progression. And honestly speaking, why was it cephalocaudal? Again, because the facial skin is very thin and it has a lot of fatty tissue. So the bilirubin is appreciated, jaundice is appreciated well in the eyes and the face earlier than the chest and the abdomen, and it is least seen or last seen in the soles and the palms. So that's why there is a concept that there could be cephalocaudal progression. It is also related to the blood supply and the blood flows. So that's why people came to a very crude understanding that facela 5 and upper chest 10, but it no longer probably is going to correlate. And in today's time and era, we have other ways of measuring bilirubin. So probably Kramer's rule is outdated, and also very important, Kramer's rule is only for full-term babies and not for late preterm and preterm babies. And it cannot be helpful once the babies are under phototherapy. So I think
Yes,
these are few.
Deshmukh
Yes.
sir wants to
Nice,
answer.
Sandeep. Let Sandeep finish.
So this is how we would obviously see. So 2 or 3 prerequisites. Never comment about jaundice in artificial light, always in daylight. Never comment about extent of jaundice based on a baby which is under phototherapy, and never comment about extent of jaundice in late preterm and preterms based on Kramer's rule. So it's applicable only for full-term babies who are well-looking babies. Otherwise, these are some of the handicaps of clinical judgment, and one would make some errors or mistakes. Yes, sir. Deshmukh sir.
Yeah, Sandeep has explained it. I just want to comment about Mohit sir's question because he's always into science. That I appreciate. The basics of everything, the basics of mechanism. So student in him is still alive. And we used to read, I read it somewhere long back in the Kramer icterometer, that it saturates the proximal sites initially this bilirubin because of the vascularity, central vessels, the closer vessel, the face is vascular and all that Sandeep has told. And then it goes to the peripheries. So that was the thesis of theory put behind it by the Kramer.
Okay, sir. Sandeep sir, there is a question. Please tell about the role of phenobarbital.
Phenobarbital was used in prolonged unconjugated hyperbilirubinemia once upon a time, but in today's time and era, and basically because of its mechanism of action being activation of UDP glucuronil transferase enzyme, but it should not be used in babies with prolonged jaundice for a very simple reason that babies may be sedated, and thereafter the feeding is depressed or feeding is decreased, which in turn is going to increase the intrahepatic circulation and might increase bilirubin. So there is hardly any role of phenobarbital in prolonged unconjugated hyperbilirubinemia.
Okay, sir. You have already answered the cephalocaudal progression of jaundice, which was asked by one of the participants. There is one more question. RH incompatibility. If the cord blood DCT is positive, can we give IVIG initially or directly go to exchange?
I think the point is very clear. We want to avoid exchange, and we want to avoid the neurological damage. So if you know that, if you feel that this patient is at risk, but you want to avoid exchange, then that is the time we have to give IVIG. So this is the ideal candidate for IVIG. And just one more comment about what Kadam sir said, just an addition. Phenobarbital is neuronal killer. So avoid it.
Yeah. On day 2, if the total bilirubin is 18 with direct of 4, will you give phototherapy?
Yes. Once again, it is the total bilirubin. And when we have a direct component which is high, that is going to increase the free component of bilirubin. So whenever we are considering in first week of life, the time of phototherapy and initiation of phototherapy, it is the total bilirubin that we are considering.
Okay. Thank you so much, all.
Covalent bonding. See, what is the difference between a normal bilirubin and a direct bilirubin? This direct bilirubin forms a covalent bond, and then it becomes very difficult to segregate, and that's why it increases the free component.
Okay. I think all the questions in the box has been taken. Do anyone want to add anything?
Victor, in your case, you did serum albumin in the first case. Any reason for
that? Why we say the fear of 25 is because the assumption is 1 gram of albumin will bind around 7 to 8 milligrams of bilirubin. Okay. So if you have a normal neonatal albumin level is 3 to 3.5 grams. So if you have 3 grams of albumin, then it will bind somewhere around 24 to 25 milligrams of bilirubin. That is the assumption. Now the issue is in neonate the albumin binding. Now this is the adult. 1 gram of albumin binds 8 milligrams of bilirubin in an adult. In neonates, this binding might be slightly less. In sick neonates, it will be less, and then the medicines that we administer will be displacing this albumin binding. But what we usually do, if you see, there are charts, even in this AAP charts, there are albumin binding and these ratios also. So here we have albumin. So this albumin was, I think, I don't remember, 3.5. So I am at my core. I feel safe that even if this age is whatever is this age, he is going to bind more albumin and being safe neurological.
Okay.
One question to Sandeep, if you allow.
Yeah, sir. Please.
All the list of cholestasis that are given prolonged, the UTI, fungal infection, sepsis, galactosemia, I assume they should be causing conjugated. You said they start with unconjugated and later on become conjugated. What's the exact mechanism? What's the mechanism for it?
In urinary tract infection, it is low-grade hemolysis.
Okay.
Similarly, in infections, it is hemolysis initially and then cholestasis and hepatocellular injury. So these are some of the ways by which you should start thinking about alternative diagnosis.
Thank you.
Okay. Thank you. Yeah, Jayant Upadhyay, sir, please.
Yes, sir.
Yeah.
Sandeep, good evening. Good evening, everybody.
Good evening,
Sandeep,
sir.
Good evening. A premature baby is coming on 2nd or 3rd day, of which bilirubin level when you test at your setup is more than, say, 20-22 total bilirubin. Majority is unconjugated fraction. The rate of rise after admission is more than 0.5 per hour. So it is a routine experience to organize an exchange transfusion that to organize the exchange transfusion takes a lot of time to arrange blood, to arrange the personnel, to arrange all paraphernalia. So, what will you advise in such circumstances? See, for a routine neonatal setup, big hospitals, it is easy. The things are easy as I myself have the experience. But at periphery, it becomes very difficult. So what needs to be done in such circumstances? Of course, doing exchange transfusion is of paramount importance. I know that. But we try to give double surface phototherapy and give other medicines, stop injectables like ceftriaxone and all other things. What will you advise?
The first and foremost, we need to know the cause of jaundice, whether it is Rh, AB, or minor blood group. The very fact the bilirubin is 20 to 25 on day 1, day 2, it is most likely due to hemolysis.
Yeah.
So we need to arrange for exchange as early as possible. If not, then at least O cells with AB negative plasma, any blood bank would have cross-matched with mother. Until such time that you get blood, you give intensive phototherapy from all the 3 sides with IV fluid to hydrate the baby. And in that case, you would not give oral but give a OGT feed, so that you are giving continuous intensive phototherapy to at least see that the bilirubin does not rise any further, if not decrease, and do an exchange as early as possible.
Sandeep, is there any role of albumin in that situation?
If your serum albumin is normal, then one should not give albumin. Because people used to give albumin and then do exchange, but that was an outdated practice now. If the serum albumin is 3 grams or 2.5 and above, then it has its own hazards of giving albumin by virtue of its osmolarity and colloid nature.
What is role of IVIG in such circumstances?
Actually, sir, IVIG may not be indicated in such situations except RH, and also the recent NICE guidelines.
RH incompatibility, I am saying, very fast rising, direct Coombs test positive, and
the dilemma here would be, if you give IVIG, you may still have to do exchange. That IVIG will go in the exchange bottle, so it may go waste.
Maybe the money is wasted, but does it have any positive effect till the time we organize for exchange transfusion?
It is a very hypothetical situation, sir. You may probably not do harm, but if you read the recent NICE guidelines, IVIG is probably not recommended for even for RH. The recent NICE guidelines from UK.
Okay.
Okay.
Yes, Deshmukh sir, yeah, please.
I just want to comment on the IVIG thing. I guess IVIG, though the evidence is not very strong in favor or against IVIG in hemolytic disorders. And as Dr. Jain sir was saying, in that situation, that can happen because exchange transfusion, arranging exchange transfusion is a hell of a job. Many a times it may not be arranged. There will be a lot of difficulties. I guess I would rather prefer to give phototherapy, intensive phototherapy plus IVIG rather than not giving it, whether it is RH or ABO, because unit-wise the protocols are different. Because you see, the initial 3 or 4 hours, the trials of IVIG, if you look at them very closely, there the IVIG was used only after failure of phototherapy. So probably simultaneously, if you start, because you are buying some time in any ways, prevent the neurological damage, that is the first top priority. So that is what is my comment is. And apart from this, I just want to comment on 2 or 3 things. One is the sunbath. There was a question of sunbath and not sunlight. Sunbath is good for the doctors. That is number 1. We need to go more in the sunlight and not artificial light. Secondly, Sandeep has clearly mentioned about that. Because there are countries where the electricity is a luxury, but the sunlight is abundant. And those studies, they are there where the filtered sunlight, the canopies are made with the filtered sunlight, because there is a hazardous sunlight, as Sandeep has clearly told. So if you can manage, or maybe there is a device, then maybe sunlight. But in India, I don't think that situation may arise. So that is out of question. So I used to teach my postgraduates, use sunlight if phototherapy is not indicated. Those babies who do not require phototherapy, give sunlight. So that is sunlight thing. Second is, I just want to comment about intermittent phototherapy. Is there any role of intermittent phototherapy? Because there are in smaller units. There may be 2 or 3 babies and there are only 1 or 2 units, phototherapy units. So continuous is always preferable, number 1. Let that be out of equation. Second, is there any role of intermittent therapy? Yes. In babies who are stable, but in phototherapy, indicated phototherapy, and then there are no risk factors for severe hyperbilirubinemia, you may definitely give intermittent phototherapy. It has its advantages. And mind you, phototherapy is not without hazards. It's not a benign therapy. And most important for me when giving phototherapy is the anxiety and stress which the family faces. The cost of hospitalization, going to the hospital, the family is affected, bonding is affected. So phototherapy should be used judiciously. And secondly, it should not be used excessively. Every jaundice should not be treated with phototherapy. Because paradoxically, bilirubin, though causes neurological damage, it is the most potent and powerful antioxidant in early neonatal period, when the baby is facing maximum oxidant stress. So let it be there if in the physiological range, not in the danger zone. Monitor the babies closely. And intermittent therapy, phototherapy is very good because then you are allowing time for the mother to have some, maybe giving KMC, giving breastfeeding, cuddling the baby, developing the bonding. So all that has to be taken care of. And iPads have to be removed when you are giving the baby to mother. Even in continuous phototherapy, mother should be allowed to handle the baby and cuddle the baby, and intermittently remove the iPads, because the bonding, it has to be established. And there is a question mark during this COVID times about this bonding thing. My teacher, Irani madam, used to ask me during this COVID times, I spoke very often with madam. She always used to tell Deshmukh, what is happening to the bonding? These, even otherwise, if not phototherapy, the mothers are masked. They are not seeing the full face of the mother. They are seeing just the half face of maybe the eyes, because they are wearing the caps also. So that has to be little taken care of, because it definitely reduces the stress of the mother. It has to be mother-based care. And if it is the unit permits or unit have that facility, in babies who do not require intensive phototherapy, it is preferable to give with the at the bedside of the mother. So these are the few comments I just wanted to make.
Yeah. Yes, Dr. Amit Tagare.
In Jain sir's case, the thing is, whenever the bilirubin level is beyond 5 milligrams above the exchange level, IVIG is not indicated, because it is not going to work. And IVIG is not going to reduce the bilirubin, it is just going to reduce the hemolysis. So ideally in such patients, just intensive phototherapy, hydration, and as much as early we arrange the exchange.
Okay. I think we come to the end of the session. So I thanks Dr. L.S. Deshmukh sir for the excellent pearls and being the mentor of today's program. Thank you so much, sir, for sparing your valuable time and inputs. I thank our mentees, the speakers, Dr. Sandeep Kadam sir, Dr. Amit Tagare, Dr. Amit Dahar, for the excellent, clear and clinically oriented presentations. It was extremely useful for our pediatrician friends. And also I thank the guest of honor, Dr. Vinay Joshi sir, who is EB, Maha IAP Mumbai, for his time. Dr. Hemant Gangolia, the president of MAHAIP, who had started this program. I also thank Dr. Mahesh Mohite sir for this idea of this mentor mentees, and for his today's question and answer questions he has asked, and excellent participation also. I thank Dr. Upadhyay sir for joining us, and Dr. Nilima Bhandarkar for being the other moderator. And last but not the least, all the learned audience who has joined today, our dear friends, colleagues, seniors. I thank each one of you for the interactive session, and thanks for joining till the end and appreciate our speakers. And not the least, our digital partner, Mrs. Pallavi Dharmadikari, for giving this platform. Thank you, everyone.